Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.AAAAI.org. Today's edition of our Conversations from the World of Allergy podcast series has been accredited for continuing medical education credit. The American Academy of Allergy, Asthma, and Immunology is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. Information about credit claiming for this and other episodes can be found at www.education.aaai.org/podcasts. Credit claiming will be available for 1 year from the episode's original release date. Today, we are pleased to welcome Dr. Tamara Perry to today's episode. Dr. Perry is the chief and professor of the Allergy of Immunology Division at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital in Little Rock. Dr. Perry has led a distinguished career as a researcher and clinician, focusing her efforts on improving health outcomes for children in rural and underserved communities, including a lot of work using telemedicine and school-based approaches to assist asthma management. In addition, Dr. Perry is a current member of the board of directors for the American Academy of Allergy, Asthma, and Immunology and chair of the Committee on the Underserved. Dr. Perry is an excellent guest to help educate us all regarding today's discussion surrounding asthma disparities. Neither Dr. Perry nor I have any relevant relationships to disclose for today's conversation. Dr. Perry, thank you so much for taking time to join us and welcome to the podcast.
Well, thank you. I'm delighted to be here today.
Okay, well, we're going to learn so much from this conversation, and it's so topical and important. But before we get into the content, we're recording this right now in August of 2020, a time marked by a global pandemic due to COVID-19, and we also have tremendous societal unrest that was initially sparked by the murder of George Floyd several months ago. And I've been asking a lot of our guests the very same question before we get into things. But if you're willing to share, how are you doing?
Well, thank you for asking. I think I'm doing well, all things being considered. Obviously, like everyone else, I've had, some increased stress and frustration. I've had to learn to adapt to uncertainty. And, obviously, we've had a lot of changes in the medical community. All in all, I've really tried to focus on some of the positives, like having an opportunity to spend more time, at home with my family. Just being a little bit more intentional about making those connections with families and friends, and fortunately, I've been also able to take up a new hobby. I've been cycling a few times a week, so trying to look at some of the positives, in a very stressful time that we're all experiencing together.
I appreciate you sharing that. Is it outdoor cycling or are you doing something inside on a stationary
Yeah,
cycle?
so I've been doing outside cycling. My husband and I both bought bikes recently, and we've been going a few times a week and loving it. It's great to get outdoors, especially, since we can't travel or do some of the other things that we're typically doing at this time of the year.
Oh, that's a great outlook. And I know we try to buy new bicycles for our children, and apparently there's a huge shortage on all things that have to do with outdoor activities, and rightfully so, because everybody's thinking the same thing.
Yeah, that's true. The shop where we purchase our bikes said that they've been busier this summer than they've been in decades.
Oh my goodness. Well, I appreciate your perspective on your personal challenges and how you've adapted. But, what about in regards to your professional career? Have the events over the last several months changed anything for you in regards to your approach to caring for patients or some of your research interests?
Oh, definitely. Just like we in the medical community have experienced a lot of stress and anxiety and frustration, I realize that our patients and their parents have as well. We've all had to adjust to a new normal. So, some of my parents who previously worked outside of the home are now working out in the home and are kids are, faced with virtual or homeschooling, and maybe even dealing with more serious issues like illness or financial struggles. So I've really tried to slow down a bit and listen to their concerns because
Mm,
I know that those concerns impact their medical care. So just being a little bit more intentional about those conversations. And, I think just like providers, our patients have had to quickly adjust to some different modes of therapy and modes of communication with their providers. Many of us are utilizing telemedicine more, and so this is all new for our patients as well. So just trying to be patient and intentional in conversations with the patient.
I'm sure a lot of patients are, it may not even occur to them, or they may not be forthcoming to bring these things up with you. But, as you mentioned, we're all going through challenges. Do you have any examples of some of the conversation starters or questions that you use to sort of elucidate some of this information?
Oh, absolutely. So usually I just, ask a straightforward question, like, how are you coping
Mm,
with this pandemic? And, I've had a lot of patients and their parents who are very honest about how stressed they are, the struggle that they're having, especially at this time of the year when parents are struggling with how and where and when their children will receive education.
Oh, that's great. Yeah, I've also had valuable conversations with families from the get-go, and I learned so much just by listening to them. So I think it's something that all of us can benefit from. And as you mentioned, it really impacts their care and their health. And we're going to talk a lot more about that as we get into today's discussion. So speaking of which, I'm looking forward to learning more about the disparities. But before we get into that, let's just start so everybody sort of has the same background knowledge and definitions that we're going to use. So can you define asthma for us and provide a description of why it's such a complicated and heterogeneous disease?
Sure. So asthma is a chronic disease of the lungs, hallmarked by underlying inflammation of the airways, increased mucus production, and variable bronchoconstriction. Commonly, patients experience symptoms of coughing, chest tightness, wheezing, shortness of breath, and oftentimes exercise intolerance. It's a heterogeneous disease that affects all ages and has variable expression, with some patients having very mild disease and easily controlled symptoms, while others can have severe and difficult to control symptoms. It's a very common chronic condition affecting 25 million Americans, and children also have asthma as one of the most common chronic diseases, with about 8% of children having 8 to 10% of children, depending on the population, having asthma. That prevalence can be even higher in some high risk population, as many of our listeners will know. Asthma disproportionately affects patients in low income and minority populations. And these facts just suggest that asthma is a multifactorial disease that results in, variable expression, and really explains the variability in patients that we see in the clinical setting.
Mm. Is there a cure for asthma?
Oh, there's not a cure for asthma, but we definitely have effective therapies that have been proven to um, allow patients to have control of their symptoms and have normal life and great quality of life, because those therapies have been proven.
Yeah. So for any patients who may be listening, if you're not well controlled with your asthma and you're struggling because of frequent symptoms or exacerbations, absolutely contact your primary care doctor, allergist, pulmonologist, and there are ways to get things under control. So that's a great introduction. Now, the next step, can you take a few moments to define disparities? What does that mean? And how does that relate to asthma? You mentioned a couple of teasers with your last introduction into asthma, but tell us more.
Okay. So disparities, well, I would define it as higher disease burden in one population compared to another
Mm,
population. Um, you can also define disparity as an inequality in healthcare access or insurance, uh, uh, decreased quality of care provided to one group compared to the other. And unfortunately, disparities in asthma, both prevalence as well as morbidity, have persisted for decades in minority and low income populations, with those populations having a much higher disease burden as well as poorer access to quality asthma care.
Mm. Now, so you mentioned that the prevalence is higher in certain minority populations. Are they just at higher risk to develop asthma in the first place, or tell us a little bit more about some of the background behind that. What influences have we discovered through research?
I think for many years we have made some assumptions that genetic or biological factors were primarily responsible for some of the observed disparities. But I think with recent advances in both genetics and epigenetics, we've found that that theory hasn't really been proven through the scientific evidence. In fact, genetics has proven that people are of different races are more similar than they actually are different from each other.
Mm.
And I'm really not aware of any studies that definitively show that genetics cause a greater burden of asthma or allergies among minority populations or are related to worse outcomes just on the basis of race. I think, one of the things that we see in terms of disparities in healthcare outcomes are largely defined by some of the environmental and social factors that are really related to race and income, particularly in this country.
Mm. Can you elaborate on some of those factors and particularly how that may pertain to certain races or minority populations?
Sure. Well, we know that about 13, in particular, because I am a pediatric allergist, so I know more of the numbers related to pediatrics. But we know that about 13% of African American children have asthma, and that's much higher than white children in the United States. And because we don't have a genetic marker. I mean, with all the genetic studies that have been done, there really haven't been any salient genetic features that have, shown us that, this is the reason why more African Americans are affected by asthma. Really, most of our studies have shown that when you go back and look at social or environmental factors such as housing, air quality, exposure to allergens or other environmental triggers, those are the factors that really impact outcomes, as well as likely impacts the increased prevalence of asthma in those populations.
So from what I'm hearing from you, it sounds like the certain minority populations are more likely to be exposed to certain environmental factors that is then influencing their increased risk to develop asthma. Does that sound like an appropriate summary?
I think that's an appropriate summary, and obviously, there probably there's a likelihood that exposure, either prenatal exposure in early childhood, all of those factors may have an impact on genetic expression of disease or
Mm,
phenotypic expression of disease. So I think that it is really important for us to think about how those environmental exposures, structural problems that children in low income environments are exposed to that predisposes them to developing asthma.
mm. Are you talking about things such as the hygiene hypothesis and those sorts of theories?
Um, well, I think it probably goes beyond that to
Mm,
some degree because we do know that in some environments we know that exposure to certain toxins or endotoxins or early exposures can be protective. So
mm,
I think that also, in terms of the hygiene hypothesis, it really does help us to see how important environmental exposures are, and how that might influence long-term outcomes, whether that's improved or worsening, the likelihood that someone may have atopic disorders.
Yeah, I appreciate you spending some time talking about that because what I'm hearing from you, and what I want our listeners to hear as well, is it's no simple formula. It's a complicated, interactions of potential polymorphisms and genetic predisposition, early life factors, and it's not just you grow up in a house with cats and you're protected or you're increased risk or things like that. So I think that's a really good sort of introduction to just how complex all of this is. And along those lines, you mentioned some of these factors that are associated with increased risk to develop asthma and higher prevalence. Do we see the same associations with just developing environmental allergies to things like pollen, animal dander, dust mite as well?
Yeah, I think so. We know from some of the prior research that in minority populations, particularly Black or African American populations, we've seen higher levels of IgE, higher levels of FeNO or fractional excretion of nitric oxide on pulmonary function testing. And so I think that some of these exposures are likely related to maybe modulation of gene expression that would relate to what we see, in the laboratory, or patients experience in terms of increased risk of atopy or having allergies.
Okay. Now, I'd like to go back to you mentioned social factors. Can you describe some of those, specifics that impact the disparities regarding asthma prevalence and just, how many people have asthma?
Oh, sure. So, well, in the United States, about 25 million Americans have asthma. When you look at the overall population of adults, that's approximately 7% of adults, 8% of children overall. And as I mentioned earlier, African American children are more likely to have asthma, with 14% of African American children having asthma.
But in regards to the social aspect of it, is it, access to care is different? Is it the type of insurance they have? Anything along those lines that we've been able to identify?
Yeah, I think we've identified a lot of risk factors related to poor housing conditions,
Mm,
poor air quality. Uh, Access to care is a major issue for some low income and minority populations. Specialty care is accessible to a large percentage of Americans, but we have many Americans who don't have access to specialty care, particularly those that live in rural environments or those who may be uninsured or underinsured. Um, we do know also that many of the large population studies that have been done in asthma have been done in urban environments. We have fewer of those types of studies in rural environments.
mhm.
But for those studies that have been done, we do know that having low income, poor housing, all of those things translate, even if the child or the person is living outside of an inner city. And in fact, our group here has done some work in what's considered the Mississippi Delta region of this
Mm.
country, which is one of the most impoverished regions of the United States, and we found, very similar asthma prevalence rates to that of inner cities.
Oh, it's interesting. Yeah, you mentioned air quality, and I'm fixated on that because with asthma, obviously with a respiratory condition, I would love your thoughts on, how do you assess that when you have patients in a clinical encounter? What kinds of questions do you ask? What are the important exposures both inside and outside the home that impact air quality and potentially impact asthma as well?
Yeah, so one of the things, obviously I currently don't practice in an inner city, but I think for our listeners who may live in or who are practicing in inner city, air quality is probably more of an issue because of traffic and dense population environments and pollution. So that those are things that you can definitely ask about. Are you living in an area, a large metropolitan or urban area with traffic and lots of air pollution? On the indoor environment, the number one issue that our patients have is exposure to environmental tobacco smoke in the home.
Mm,
And so I always ask about that and make sure that I educate our families about that risk, because that is definitely something that triggers asthma and can also be responsible for poor indoor air quality. We do know that about 30% of kids live in the home with a smoker, or asthmatic children live in a home with a smoker, and that's probably one of the most modifiable things that we can do in the home to help our patients with asthma.
mm. We've done a great job at my institution in Columbus, Ohio, where we've trained parents over the years. When we ask about, indoor cigarette smoke, every single one of them says, yes, we smoke, but we always smoke outside. So do you have
Yes.
do you have do you have any tips for our listeners about, how do you bring that subject up? I know it can be touchy for some folks. I've had great success just straightforward asking about it, but how do you ask about
Oh goodness, I think all smokers smoke outside. I mean, they know
it?
how to answer that question, right?
Yeah.
Because they don't want to disappoint the doctor. But I just, I try to be real with the parents of my patients and say, just tell them the facts and say, and I'm not judging
Mm,
them. I just want to create the best environment for their child and give them some pointers on what they should do, to actually decrease that exposure, which is actually smoke outside, remove the first layer of their clothing once they come back in, make sure that they are considering the car as a significant space where the child can be exposed to environmental tobacco smoke. If someone's smoking in the car, that should stop immediately. And just tell them what I know in terms of resources that are available to them. Also, if they're interested in stopping or quitting.
mm. This is great. I'm hearing you say sort of over and over again in subtle ways of, one, it's important for all of us just to be aware of the factors that really impact these disparities. But then we have to take it the next step, and we have to actually ask the questions when we're seeing real life patients in the office, and then we have to be able to offer them something
Right.
whenever they tell us that they're having these exposures.
Yes, I think it's so important for us to, not to take those interactions lightly, because I think
Mm,
that everyone wants what's best for their child. And the majority of patients, if they're adult patients who, are struggling with quitting tobacco smoke or cigarette smoking, you know, they would appreciate you as a provider listening and helping them with that problem if it's something that they want to do. If we can help them and provide those resources, I think they would be very appreciative.
absolutely. Now, we spent a lot of time talking about asthma prevalence, and it was well established now that minority populations and those with various social factors, environmental factors, have disproportionately higher rates of developing asthma. But does that also translate to differences in their level of asthma severity?
I think it can in some to some degree because the exposure to those conditions that we talked about is more prevalent in those populations. So exposure to triggers, poor access to specialty care, and also uh, poor access to or I'm sorry, not poor access, but more access to emergency or urgent care type settings in those populations is more prevalent. So we do see, or it seems that for those populations, the level of asthma severity may be skewed towards being more severe. But again, I think it's really hard to tease out if it's actually worse disease or if it's related to some of these other factors that we've identified.
Oh, that's a very important concept and just another layer of complexity to the entire issue. You mentioned urgent care visits and emergency room visits, but when we talk about asthma morbidity, is it just really, urgent healthcare utilization, or are we talking about other factors as well that impact somebody's life?
Oh, absolutely. So, emergency room visits are very, obviously costly and important, but also looking at utilization of other urgent care, healthcare services, such as hospitalizations or sick visits to the regular doctor or to an urgent care clinic. And then also, we have to think about morbidity as looking at things like decreased quality of life, increased medication use, and also some of the psychological factors that or impacts that asthma may have on someone's life.
What about school attendance, work, things like that? Does that sort of fall into this category as well?
We definitely see direct medical costs as well as indirect medical costs increase due to asthma. And we know about 500,000 hospitalizations annually in the United States are due to asthma. 1.3 million emergency room visits due to asthma annually are have been reported. But then you have to look at the indirect costs associated with asthma, including decreased productivity at work, decreased or missed school for children. And some of those statistics are staggering when you think about asthma for children in particular. They miss more than 13 million days from school due to asthma, which is a completely treatable disease.
Yeah, no, those are sobering statistics. And speaking of, one statistic that I rarely, if ever, hear about, especially in the media or in the mainstream conversation, is in regards to people dying from asthma. But can you inform our listeners about some of the statistics surrounding asthma mortality, and also if this disproportionately affects minority populations?
Yes. So we don't hear about death due to asthma very often. Fortunately, there has been a decline in the death rate due to asthma over the last few decades, and some of that has likely been related to improved therapies for asthma. But even though we have those therapies, about 10 people a day die from asthma in the United States, and again, Black and African American patients have a significantly higher mortality rate compared to whites and all other age groups. One statistic that sticks out in my head is that Black or African American patients die at a rate 3 times higher than white.
Oh my gosh. So, and you're describing a chronic condition that impacts millions and millions of people. And yet, you've also discussed how it can be controlled, and a lot of these can be prevented. And we still have, as you mentioned, 10 people dying a day on average from asthma in the year 2020. That is, something that I hope we hear a lot more about, in the competing headlines these days. But, speaking of management, we know that it requires a lot of education surrounding self-management, the ability to recognize symptoms, know when to treat, how to treat, and especially those with more persistent or severe disease, they have to take daily medications multiple times a day, control their symptoms, avoid exposures, all kinds of nuances to individual care. But can you talk about some of the specific challenges impacting populations at risk, and how that negatively impacts their ability to effectively control their asthma? I mean, what challenges do they face in regards to self-management?
Yeah, so just like we were talking about asthma in and of itself being complicated, treatment of asthma can also be complicated for many patients. We've had asthma national guidelines for the treatment of asthma for a couple of decades now, But for some populations, and particularly low-income minority populations, we know that those populations are less likely to receive the guidelines-based care. They're less likely to be prescribed, the standard therapy, which is inhaled corticosteroids. They're also less likely to receive a referral to an asthma specialist
Hmm.
and more likely to receive asthma care in acute care settings like urgent care clinics or the emergency room, which also decreases the likelihood that they would receive, the proper counseling or education that they need that would help them to effectively manage their asthma. And then, further, I think patients in these populations are even also at high risk of being uninsured or underinsured, and they may not be able to afford the medical therapies that are prescribed to them.
Wow, so that's a big problem if you can't actually get the care that you need.
Right.
Oh, so oh boy, a lot more to unpack there. But what about those who are prescribed medications and the therapy? And there's that's a whole separate conversation about the variety of controller medications and rescue medications and ways to use them and things like that. But are there identifiable characteristics that may occur more frequently among asthma patients from different racial or ethnic backgrounds that impact the way their bodies simply respond to specific medications?
Well, I think the evidence for causal genes is has been, I would say, kind of weak.
Mm,
I think that we have seen some, better or worse response to some medications among different ethnic populations. For example, there've been some studies that show that African Americans may respond better to inhaled corticosteroids compared to leukotriene modifiers. But I do think that some of that, is also, potentially related to, I think it's just really difficult for us to tease out all of those, of what we see, those observed changes, medication responses, without looking at, the social context. Maybe those patients
mm,
are exposed to different environmental exposures or triggers that would lend them to be more susceptible to a better response to certain medications. So I think we have a lot more to learn in this area.
Yeah, it's a lot to control for if you're trying to figure out, like you said, what factors are actually, impacting response to specific medication. Uh, sort of off the cuff here, in your experience and opinion as a researcher, do you feel that minority populations are adequately represented in research on asthma?
I don't. I think in general, African Americans and minority populations in general have not benefited from, in particular, some of the pharmaceutical trials.
Mm,
When you look at those studies, the African American population is generally much less than what we see in, well, the population of participants in the study is much less than what we see in the general population. And because we know that African Americans and other minorities have a disproportionate burden of disease, I think it's important to maybe overpopulate studies with patients from these populations so that we can learn more about response to medications.
oh yeah, that would be fantastic. What about community-based programs? What sort of programs have been developed, and more importantly, which ones have been shown to improve asthma outcomes among at-risk populations?
Well, fortunately, we've had a lot of success with some therapies that include school-based therapies for kids, or interventions. I'm sorry, school-based interventions for kids, home-based interventions, and I think some of the most successful ones have been those that take a multi-pronged approach, because as we were saying earlier, that this is a complicated, multifactorial disease. So, not only addressing the medical needs, medication needs of the patient, but also maybe addressing some of those exposures and things that happen outside of the medical clinic. Those types of interventions have been really successful. And I think some of the more successful ones have been those that have been developed with community people in the community who are invested, building some partnerships, community advocates, so that, for instance, children who attend a community center after school, or
Mm.
have a directly observed therapy done at school or in an after school program. Those types of programs have really been successful in improving outcomes for patients.
Oh, and it makes sense. I mean, you described one of the major barriers to effective self-management is a simple lack of access to care. We've been, expecting patients to come see us, but if we can actually go to them where they live in their community and their environment, it sounds like a win-win for everybody involved. Now, right now, hopefully we have listeners from all over the United States and often from other countries as well. And we talked before about the importance of not only increasing our awareness regarding these important factors, but then addressing it, when we're seeing patients. Do you have a call to action for all of us? Are there tangible things that we can do to help individual patients? What would you like to see, listeners take away from this on a practical level?
Well, I think we all have, as providers, a skill set that we sometimes don't always put into practice. We definitely know how to identify and treat, asthma, utilizing a national guidelines as our, guide. But one of the most important things I think clinicians can do to help individual patients is to listen, identify, and respond to social factors that might be contributing to adverse health outcomes. And we really need to treat the whole patient, and that might mean, digging a little bit deeper in your questions. It might mean, slowing down and just listening to what is being said without being said, because sometimes people give us little messages without actually saying the words. So I'll give you an example, because we all struggle with this. You're in a busy clinic. You may look at, prescription profile of a patient and see, oh my gosh, they haven't picked up their, controller med in 4 months, and I don't understand why, they haven't done that. And so, I had a recent encounter where that happened, and I talked to the mom, and I'm like, I don't understand. We've talked about the importance of taking controller meds. We've talked about, that this is a controllable disease, and, your child does not have to miss school, doesn't have to sit out from basketball. So there's something missing. And, she just, told me, she's like, well, I don't have a car right now. And
Mm.
I can't get the meds. I don't, I don't have transportation to get to the pharmacy. And so it's like a light bulb. I'm like, oh, that makes sense. If you can't get to the pharmacy, you can't pick up the medications. And so, we made a couple of phone calls, and we were able to get home delivery for that patient. So, I think that that is one thing that I hope that people will take away from this, is that, sometimes, we have to think and not judge why something may be happening in a patient's life, and help them problem solve. When we identify, those social factors that may be impeding our care, we can utilize our resources to help, the patient's problem solve.
Mm. Do you have any training in, or do you utilize motivational interviewing during these interactions?
I don't have any training formally in it, but I think with some of the research that I've done, and just, being in practice for many years, I do try to employ those tactics when I'm speaking with patients.
Yeah, yeah. As you mentioned, a non-judgmental conversation. Really, we're just trying to help them, and they're trying to help their child. Absolutely. Now, you mentioned that there's a lack of representation among minority populations, especially in pharmaceutical research and clinical trials and things like that. But what do we actually have that currently exists in regards to either efforts that are being done for research in this area, funding pipelines, and advocacy? Can you give us some more information regarding that?
Well, there are definitely some new and exciting initiatives. I recently, have been looking more into funding opportunities through some of our national and federal funding agencies that are looking more at anti-racism research and research that addresses structural and social inequities. And so that's really exciting. And then we also have a lot of research currently looking into technology-based solutions, which I think is going to be vitally important, utilizing telemedicine and mobile applications to help with the healthcare delivery. So those are some really important and exciting things I think that are happening in the research community.
That's great. And you mentioned telemedicine, which is something that was foreign to almost all of us just 6 months ago, and now almost all of us are doing it to some degree. But you've been doing it for a while, and I'd love to hear more. Can you tell us about your work using telemedicine services and school-based approaches to help patients living in rural areas where you are?
Yes, so it has been really an uphill battle. I think medical providers or the medical industry has been far behind many other industries in terms of the use of audiovisual technology, and we were thrown into the fire in March. Uh, so I was really happy about it, being in my position as medical director of telemedicine. We, of course, we're crazy busy with trying to get people started with telemedicine, but I really feel like even pre COVID, that medicine was going to eventually get there. We just got there a lot faster than we had previously anticipated. I think that consumers, patients, are going to not only want but demand to some degree that their providers offer some telemedicine solutions. And we've, I think, seen throughout this pandemic that telemedicine can absolutely enhance our practice. There are some patients who we can speak to either, over the phone or via video visit to handle some simple problems. And in particular, for people who live in rural areas, it is really, really convenient and helps to improve the care that they receive if we're able to see them while they're still in their community. Think about, some of my follow-up patients who, I need to see periodically, but I may not need to see them every single visit, especially if they're doing well or if, they have a simple medical complaint that I can handle via telemedicine. I can save them time traveling. I can keep the parent, at work and the child in school. So I think it's a win-win solution, and I'm really excited. I hate the circumstances under which we became more able to see all of these patients via telemedicine. But I think on the other side of it, medicine will benefit.
It's one of the few silver linings throughout all this, right?
Yes.
Yeah. Now, what about asthma specifically makes it so great for telemedicine?
Well, I think, with our program here, we've been doing telemedicine follow-up for a couple of years via telemedicine. And it's so perfect because, obviously, per the national guidelines, for patients with persistent asthma, we should see them several times per year to actually help with medication management, monitor for side effects, and again, some of those visits absolutely need to be done in person, but not all of them. And we've been able to successfully utilize peripheral devices to actually conduct physical exams for patients remotely. We've also been able to conduct remote pulmonary function testing and really provide care, that's comparable to the care that we provide in person via telemedicine. So I think asthma is one of the chronic conditions that is perfect for telemedicine. It helps us to stay in line with the guidelines in terms of frequency of visits, as well as keeps us in touch with our patients without them having to miss even more school or work just for routine care.
Mm. Oh, it's great. And, I've also been fascinated by our rapid incorporation of telemedicine, and I love it as well. I think it works out great, especially for follow-up visits and saves travel, and you can provide the same level of care in many instances. But, we've also found that this can be an area that can actually highlight some of the disparities among our patients from various backgrounds. Can you comment on some of the things we've learned in regards to that?
Oh, absolutely. So we have seen, we have been particularly plagued with technology
Mm.
limitations, internet access limitations for some of our patients who live in really rural areas of our state. So I think that this is an area that needs to be addressed, obviously at a much higher level. This, is a problem that needs to be addressed by our, federal and state and local governments to improve access to internet and Wi-Fi so that those patients who live in areas that are currently, without access can have the same benefits as patients who live in areas with those capabilities.
Mm. Isn't it amazing that something we all take for granted with the phones we have on our pockets and the power that they bring us, and yet there are segments of our population in highest need and at highest risk who just lack basic cellular service or access to Wi-Fi. It blows my mind.
Oh, it's amazing. I've read stories about families, and I think it also came to light during this pandemic when children were taken out of school, and a
Mm-hmm.
lot of schools had to convert to virtual less education, and you know families that didn't have internet access were left out. They had to go to public spaces or drive still had to drive, several miles to be able to provide that to receive that internet access. So I think it's something that's really really important to be addressed with our government.
Mm. From your personal standpoint, with all of your efforts with telemedicine and research and advocacy and everything that you've done in your location, have you physically spent time in some of these rural locations? And if so, how has that changed your perspective?
Well, I'm glad that you asked that question because yes, I have. I actually grew up in a very rural area of
Mm.
state. I actually grew up in the Mississippi Delta, so I know firsthand, some of the struggles and the limitations of living in a really, really rural area. When I was growing up, we had to go to a physician probably an hour and a half away from where we actually lived for medical care. So I think that has given me a lot of perspective on the struggle that people have in rural areas. Obviously, things are a bit different now because that was just a couple of decades ago. But I think some of the struggles still remain. That poor access to medical care, limited access to internet or technology, and having a very medically underserved regions in this country. Those things remain be problematic.
Mm. When you interact with your colleagues from across the country that also have similar efforts like you do with trying to expand care into communities in rural areas, do you find that anecdotally do they have similar backgrounds? I'm fascinated and I wonder how much of that you're growing up played into your sort of professional interest. But have you noticed that among others as well?
Um, I have in some, but I've also had plenty of colleagues who grew up in large cities,
Mm.
who have seen equally disproportionate problems in terms of access or other factors that impact the medical care that patients receive. So I think a lot of us with interest in disparities go into it because maybe some early life exposures to those conditions, or just an interest because we recognize it as a major problem and a gap that needs to be filled.
Hmm. Oh boy, Dr. Perry, I could talk to you all day about this. This is fascinating, and I want to be respectful of your time though, and thank you so much for joining us. This has been extremely informative. Before I let you go, is there anything else you'd like to add?
Well, I'd just like to say thank you so much for addressing disparities in asthma and giving me the opportunity to discuss it. It obviously is a passion of mine, and I am very hopeful for the future. I'm excited about some of the initiatives that we spoke about in terms of increasing the utilization of technology and more research into the social factors that play a role in disparities. So thank you so much.
The pleasure was all ours. Thank you. We hope you enjoyed listening to today's episode. Information about credit claiming for this and other episodes can be found at www.education.aaai.org/podcasts. Credit claiming will be available for 1 year from the episode's original release date. Please visit www.aaai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through iTunes, Spotify, or Google Play so you can receive new episodes in the future. Thank you again for listening.